Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. HIP.
Jacqueline has volunteered to be our patient for a hip exam today. Hip exam consists of two projections. You have an AP pelvis patient, you shoot AP projection, the pelvis is your focus. So we'll be using a 14 by 17 to include the entire pelvis. Then we need a lateral of the hip of interest. It might be a unilateral hip one side, it might be both hips bilateral. I'm only going to demonstrate one today. You have a choice of laterals that we're going to demonstrate. The first one we'll show you is a frog leg hip. And the patient's basically kind of very similar to a frog position. That's not the common one. The common one is a cross-table lateral. I need to make sure that you understand that it's an either-or situation with the laterals. Frog leg, maybe 20% of the time. Cross-table lateral, because most of the time you're taking these for a trauma situation. The leg is not very mobile. We shoot cross-table. That's a cross-table hip. So a hip consists of what? Two projections, AP pelvis, and then a choice of the lateral. What were your choices of the lateral? A frog leg hip or a cross-table lateral hip. So let's start the demonstration of the AP pelvis first. Patient is recumbent on the table. I'm using a 14 by 17 film crosswise. I think you can see that it's in a crosswise position. The ID marker is towards the wing of the ilium. It's not, if it wasn't here, it would be down over there, which would be over on this side of the patient near the trochanters. More problems happen over the trochanter region, so we keep it up by the crest region. Okay? So ID blocker is towards the technologist, in other words. I'm going to use an R marker. Usually we try to put the R markers to the corners, but because of the unusual shape of the pelvis, the wings being wide, then it dips in, and then the trochanter comes back out, I'm going to put that R marker in the center of the cassette, hopefully keeping it out of the way of pertinent anatomy. Again, trochanter could be down here, so we put it in the center. And when we look at radiographic images, I think you'll understand what I'm meaning here better than this actual talk today. I can push the cassette in because this is a floating tabletop, and I have the tube lined up with the film. And I have my tube transversely centered. I have 40 inches SID. And all I have to do now is float my patient, and I'm going to get her mid-sagittal plane to the center of the film. I'm centering over the pelvis region, and I'm going to float the table to get the mid-sagittal plane to the center of the film here. Okay? And then what I'd like to do is palpate for the iliac crest. Previous lessons of the abdominal series, I want you to remember some things. I want you to palpate posteriorly. If you palpate anteriorly, you think you're at the top of the crest, but remember that crest angles higher as it goes posteriorly. So I'm going to feel posteriorly. I'm going to palpate firmly with my fingertips. I'm going to kind of reverse my position here so you can see from a camera angle what I'm going to do. I'm flat-handed. I'm not coming in poking that patient. They will jump off the table on you. But flat-handed, both sides. I've warned the patient what I'm needing to do. I'm telling him that I need to palpate for the borders of their pelvis region. And I'm feeling bone, hard bone, and then there's the iliac crest. Notice I'm posterior, and I found the iliac crest. Flat-handed, then I can focus in on the tip. There's the iliac crest. So I'm going to find that. If you cannot see or palpate the inferior borders, all you have to do is put the film's edge 2 inches above that iliac crest. Okay? I can palpate for the trochanter on the side here, and I feel it right there. The trochanter is at the level of the pubic bone. Okay? So I'm identifying the superior border, I'm identifying the inferior border of the pelvis, and the center crosshair should be right here. Okay? You can see how that light is not centered over my fingers. So I need to float the table. And now I think you can see that the crosshair is in between my two fingers. And then let's look here. Here's the iliac crest, there's the film's edge. Film's edge is 2 inches above. If I was unable to feel for the trochanters, or if I was unable to see the pubic bone, just go with film's edge being 2 inches above her iliac crest. Okay? Make sure she's not rotated. Make sure she's not tipped. You want to look at the ASIS and make sure they're the same height from the table. This would be rotated. You don't want that. Or this would be rotated. Don't want that. You want that pelvis. So the ASISs are the equal distance from the tabletop. No rotation evident. The last thing that you do is you come to the end of the table and you ask the patient to invert their feet about 15 degrees. I'll let you look at her feet here now. Okay. What does this do? This prevents the anti-eversion of the femoral neck. In layman's language, the greater trochanter will be better in profile, and your evidence will be the fact that the lesser trochanters are going to be barely visible. Let's focus back on the feet for a minute. If the patient came to the department and the foot was flat, naturally the foot is kind of in a semi-relaxed position like this. If the foot comes to you with flat, this is a pretty strong indication that you have a fractured femoral neck or head region. Do not invert this foot, okay? And what you ask the patients to do is spread their heels and see if they can point their feet inward. If it's hard for them to hold, you can ask if you can put a little piece of tape around them. Most of the time it's fairly easy for them to hold. Okay, this is an AP pelvis. I will hit the high points again and tell you what the image will look like. You want the film's edge 2 inches above the iliac crest. Whenever possible, center your anatomy. So I found the trochanters, or I can see the pubic bone, and I centered the pelvis. And I centered the pelvis this way, which means the mid-sagittal plane to the center of the film. I made sure that there was no rotation. If there's no rotation, the wings of the ilium will be symmetrical. The two sides will look alike. The obturator foramen will look alike. If there's rotation, let's kind of mock that, Jacqueline. Slight rotation. What that does is this wing of the ilium becomes wider. This one becomes more narrow. And what happens to the obturator foramen is when the wing becomes wider, the right obturator foramen actually becomes smaller. Okay? Let me say that again. On the same side of the patient, if this wing is wider, this obturator foramen will be smaller. And on a radiographic image, you look for those landmarks to determine if there was rotation or not. The wing that is wider is the downside, or the obturator foramen that's the small, that's appears smaller, is the downside, or vice versa. No rotation evident. Make sure that patient's pelvis is flat. When you invert the feet, your evidence will be that the lesser trochanter will be barely visible. No more than, say, an average tip of a thumbnail with some white on it. Barely visible. That will indicate that you've done a good job with the pelvis in an AP position. Patient should be straight. They're in a gown. They should not have underwear on. Rotate the feet inward whenever possible, but if that foot is flat, do not attempt to rotate that. It is more than likely fractured. That's your AP pelvis. Okay? The patient would take in a breath in and blow the breath out before you make your exposure. Okay. Once you take your AP pelvis, you will do one of two laterals, a frog leg or a cross table. I will demonstrate the frog leg first. We're focusing right now on the hip, which consists of the acetabulum, the head, the neck, shaft of the femur and the greater and the lesser trochanters. I'm going to demonstrate. I think a left will be easier for the camera to see. Okay, so the left, I'm looking at the anatomy here, and here's the acetabulum, and the femoral shaft goes that way. So if I look at the cassette, here would be the acetabulum, and the femoral shaft would go that way. If the cassette was like this, here's the acetabulum, femoral head, and the shaft would go that way. So I'm going to choose to put the ID blocker to the top. It's not going to be in the way in either projection. And with it to the top, it's easier for the radiologist to read. So the film goes lengthwise. Now, the left marker, think about the anatomy again. Here's the acetabulum and the shaft of the femur going that way. Do you think it would be smart to put the L marker down there? I think your better choice would be put it away from anatomy. Acetabulum, head, shaft. This will clear that. The amount of collimation will vary from place to place, from just within film's edge to maybe a 6x6 coned area. You will know how much you collimate. We're going to show about 1 inch all the way around, so I'm happy with that L marker placement there. The affected side that you're after, you bend that knee, and you don't want it bent too far. That would be too far. Or you don't want it, barely bent. It's kind of just an average. And then the leg is rotated out laterally to 45 degrees. If they have difficulty holding it, go ahead and give them a 45-degree sponge to rest on. I think you can see the sponge there. Your leg is at 45, that would be 90, halfway is 45. Okay. You're going to collimate down tight. I actually have like 7x7, which will show approximately 1 inch of collimation all the way around. It's lined up to the center of the cassette. Okay. Now, to center the patient, you're going to use some landmarks. And you will recall from your reading that you're going to use the ASIS and the superior border of the pubic symphysis, or the upper border of the symphysis pubis. Two different ways to say the same thing. You're going to palpate for the ASIS coming in from the tummy side. Here's the ASIS. It's the most prominent point. Feel on yourself. We've had this in other lessons, but feel on your pelvis, come in from your tummy side, and you're going to find your ASIS. It's about 2 inches below the iliac crest, so feel on yourself. There it is. Okay? I can easily palpate on my patient. I'm telling her what I'm doing, and I'm not getting too personal. Okay? So you find the ASIS. Now you're going to draw an imaginary line to the upper border of the pubic symphysis. I'm going to use a pencil to help demonstrate this. You do not need to palpate for the pubic symphysis. That would be too personal. That is not acceptable behavior. I'm going to find the ASIS, and I'm drawing an imaginary line to the upper border of the pubic bone. I'm just looking at it, okay? And if the camera can focus in on what I'm doing here, here's my imaginary line, and I bisect that line, and I'm going to be 2 inches perpendicular. The pencil is to outline that imaginary line. Bisect means to cut in half and go perpendicular, and I want to be 2 inches below that imaginary line. That will put the hip right to the center of the film. Okay. Now, I put the pencil on her body a little bit more than, again, it's for demonstration purposes. I do not have to palpate this patient at all once I get the ASIS landmarked. Let me kind of show you what goes through my head when we do this. ASIS, I imagine the pubic bone, do not touch. I draw that imaginary line, cut it in half, go 2 inches down. You've got some hints here. If you can see the crosshair with the camera, I'm going to have the patient move her leg just a little bit. See how that is right in the crease of the leg? I think you can see that. Okay. Now look at the lower edge of the light, and it's below the pubic bone, but it's not down into the X-ray tabletop. And this top of the light, this portion of the light is not too far above the ASIS. If you've got a 7x7 approximate field, and you've included the ASIS, and you've included the pubic bone without including too much of the tabletop, that's a pretty good indication that vertically you're centered well. Side to side, I'm pretty much midline on this patient. I'm not touching, I just have this visionary line. MSP to the center here. The edge of the light is right there. And the lateral border, I don't know if you can see from the camera perspective, but this edge of the light is barely skimming her body. So side to side, I'm happy with that centering. And when she bends her leg for me, I can see that I'm right in the crease. So without palpating personal reference lines, I have put the hip to the center of the film. I'm going to want to protect one of the ovaries. I cannot protect the other one because it is right there. Okay? A male patient on a pelvis exam, you can protect the scrotum. On a female, unless you had a shadow shield or an appropriate heart-shaped shield, you would not be able to shield an AP pelvis. Okay. And again, the leg is at a 45 degrees. You're shielding 1/2. You use the ASIS, the upper border of the pubic bone. Make sure you recognize upper border. Imaginary line. Divide that line in half, go perpendicular, and that will be to the center of your film. Have an L marker on there. If you've done a good job of positioning this, the greater and the lesser trochanter will be superimposed. I'm going to show you a trick now that might help you know that you're off. We're going to just kind of readjust here a little bit. Maybe the camera can come in a little different. Can you see the leg now in the camera in the shadow here? You can tell that here's the ASIS, and see how the light is below the ASIS? And see how the light is hanging down on the table? That should be an indication to you that you are too low. You want to have the light touching the ASIS, so you'd make that adjustment. Or if you're this way too much. Again, see how the box, this line is not midline, it's on the opposite side, and this light is not including the lateral portion of the body. That should give you a hint that something is wrong there as well. And then she bends her leg, and the crease, the center of the crease is more up here rather than down there. So that little conscience on your shoulder, looking at the collimated field, should tell you that the hip is not your center point. You need to make that adjustment. And without even palpating the body, I'm just moving the tabletop now without even feeling any landmarks, and I look to get that hip centered. Okay? That would be your frog leg. Okay, that is one lateral option. We're going to shut the camera off for a minute to get set up for the cross table lateral, and we will be back.